Hello, and welcome to the CAP Today webinar for Tuesday, October 22nd. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your moderator, and I'll lead a Q&A session after all of today's formal presentations. Today's webinar is entitled the BioFire FilmArray Meningitis Encephalitis Panel. What the heck do I do with these results? Heck is how you pronounce all those marks there in the title that you see. What the heck do I do with these results? We're very, very grateful to BioFire because today's webinar is made possible by a special educational grant from them. And today's presenters are both very distinguished clinical microbiologists. They are Dr. Jennifer Dean Bard and Dr. Susan Butler Wu, both of whom are at the USC Medical Center and Keck School of Medicine in Los Angeles. And I'll say more about each one in due course when I introduce them right before their presentations. But first, I would like to share some housekeeping ideas and hints with you. First, we recommend that you refresh your browser, and that will help maximize the syncing up of sound and slides. We do have help available at any time today with a live operator, and you see the number in the lower right-hand corner of your computer screen at 888-364-8804. You also may use the question and answer section underneath the slides to type in not only questions and comments about the content of today's webinar, which will begin shortly, but also if you're having any kind of technical problem, and we'll do our best to resolve those matters. In about 5 working days, you'll be able to revisit this webinar. We'll be posting all the slides and the audio on captodayonline.com, so you can review, share with colleagues, and experience it yet again. I want you to know that you may also be receiving some email as a follow-up from today's webinar, and so that's coming from a reputable source, and we hope that that's useful to you. Finally, it's important to note that CAP Today does not endorse any products or services that may be named within today's webinar. And furthermore, any comments or any remarks of mine are purely personal, not to be taken as official policy of CAP Today or the College of American Pathologists. Once again, I'd like to acknowledge our sponsor because our webinar is indeed made possible today by a special educational grant from BioFire. And with that in mind, I have invited a special guest to begin today's webinar, and that individual is Wade Stevenson. Let's have his slides loaded. Wade Stevenson is the Senior Vice President for Global Marketing at BioFire. He's well known to all of us in the industry, well known by most of the clinical microbiologists in this country, and he's simply going to supply us with a brief overview of the BioFire technology, and let me invite him now to start his presentation. Wade Stevenson.
All right, thank you, Bob. I'm delighted to be here. I love giving this presentation to introduce BioFire as a company and a little bit of a technology overview. My goal is to do this in 5 minutes or less and then get on to our distinguished clinical speakers. So a little bit about us. Our mission is really simple and we feel important. We're working hard to make the world a healthier place, and we feel like infectious disease diagnostics plays a critical role in that. We specifically specialize in syndromic infectious disease testing, which is the comprehensive grouping of symptom-related pathogens into one test that can offer results very quickly in a user-friendly molecular diagnostic platform that is becoming incredibly popular in the United States and more so throughout the world. We're headquartered in Salt Lake City, Utah. We have a number of these syndromic testing panels on the market today. Our RP panel, BCID, GI, meningitis, encephalitis, which we're here to talk about today. A CLIA waived version of our RP-EZ panel, a second generation RP2 panel, and then launched not quite a year ago, but a pneumonia panel. Our system is incredibly easy to use, about 2 minutes of hands-on time, fast. The run time is about an hour or less. Again, comprehensive, and because of the molecular nature of our tests, highly sensitive and specific. So a little bit of detail about how it actually works. The magic takes place in our disposable. We call it a reagent pouch. It's composed of two different pieces. Reagent storage device, which is a hard plastic piece in which we store freeze-dried reagents, everything you need to do sample prep and multiplex PCR. And then that's coupled to a chemical circuit board. And you can think of that chemical circuit board as divided up into different segments or different blisters within that pouch where we do sample extraction and preparation, and then a two-stage multiplex PCR. First in one large reaction, and then in an array format where we do our final detection. Again, here's a little animation of how easy the setup is. You put the pouch into that loading block. You then take hydration solution, and it hydrates all of the freeze-dried reagents that are stored under vacuum. You don't have to inject the fluid. The vacuum in the pouch pulls the appropriate amount. You then add sample buffer to the sample vial, and then you add your actual sample. Hopefully you're more accurate than that animation. And then you close the lid and stir by inverting it 3 times. And then you add that in a similar fashion to the sample side. And again, the vacuum inside that pouch draws the appropriate amount of fluid. And then that is it. You then put that pouch onto the instrument, and everything else in there is done automatically for you. A 65-minute run would look like this. The sample first moves into the lysis chamber, where it's lysed through a process called bead beating, and that releases all the nucleic acids. We then inject magnetic beads that are coated with silica that bind all of those negatively charged nucleic acids, and we move them over to a wash chamber where they're purified and cleaned up. Then an elution buffer removes those nucleic acids from the magnetic beads, and then we do first stage PCR, which is a large volume single chamber reaction where we've got dozens and dozens of primer pairs all doing PCR together. It's a very messy reaction. We have a lot of, we do it under very liberal conditions where we allow a lot of PCR to happen of all flavors, and it's just to enrich the nucleic acids of interest. We then dilute that down to remove any first stage primers, and then we add a second master mix and spread that over this array. And this is really where we get our high degree of specificity, because each of those wells on that array contains primers designed to amplify one of the nucleic acid sequences that might, if the host pathogen were present in the original sample, have been enriched in that first stage PCR. So here in this array, we do PCR under very specific, very stringent conditions that allow us to amplify and detect our nucleic acids of interest. And then we do our detection by melting curve analysis, and then we give you the result. All of that takes place in about an hour, as I said. Today we're here to talk about the meningitis encephalitis panel and hear from 2 people who have extensive experience with it and implementing it, and to share some of their best practices and do's and don'ts. And I'm excited to hear what they say. So I will turn it back over to Bob, and thank you for your time.
Wade, thank you very much. That's a beautifully clear and concise description of the technology we'll be discussing today. Let me now introduce the first of our clinical speakers. And let me remind you, at any time today in the audience, you can type in a question or comment in the Q&A box underneath the slides. And after our now 2 formal presentations that are remaining, I will be leading a question and answer session with our speakers. The first of whom is Dr. Jennifer Bard. She's a diplomat of the American Board of Medical Microbiology. She received her doctorate at the University of Alberta in Canada. In Los Angeles, she is the Director of Clinical Microbiology and Virology at the Children's Hospital of Los Angeles. She's an Associate Professor of Pathology and Clinical Scholar at the Keck School of Medicine of the University of Southern California in Los Angeles. And with that, I'll invite her to begin. Dr. Bard.
Thank you, Bob, for that nice introduction, and to BioFire for inviting me to speak today. And I have to say that this is probably my favorite presentation title so far, so kudos to BioFire for that. Before we get into the nitty-gritty of FilmArray ME discussion, Dr. Butler-Wu and I thought it would be important to briefly touch on certain best practices of lab testing as a reminder to the laboratorians as well as to the clinicians. And this will help pave the way for the ME discussion later on. So number 1 is that not every test that has been ordered should actually have been ordered. And in lab medicine pathology, we really act as the gatekeepers of appropriate lab testing. The second one is that lab tests will assist in the diagnosis of infectious diseases. And for a definitive diagnosis to occur, it really must correlate in the context of clinical presentation and other investigative findings. With the availability of more complex testing, such as metagenomics testing and even syndromic testing, that report and forget it about approach is really no longer good enough. And then lastly, it is especially important that we not assume that all clinicians will understand molecular testing and will correctly interpret the results that's being reported in the medical record. So diagnostic stewardship is definitely a popular buzzword right now, although it's something that has really existed in some capacity throughout. This diagram from Dr. Kevin Messakar's group beautifully lists the specific roles from clinical evaluation of the patient to diagnosis and treatment. An important section is the diagnostic stewardship side, where it really is about providing that right test for the right patient at the right time. And this is an area that is really instrumental for the laboratory to be involved and to really spearhead. I would also argue, though, that all 3 sections here listed here in this diagram requires that critical laboratory expertise throughout, from the ordering of the right test, performing the test, and then providing our expertise in the interpretation of these test results. So the challenge for the microbiologist with these more complicated type of interpretations or reports is to report or not to report. And if we were to report, how is that message being conveyed? As I mentioned earlier, results are getting more and more complicated, and customized reporting may be warranted to help guide the clinicians in the interpretation of the result, as well as for us to offer testing recommendations on additional future tests that may be warranted. With that, we wanted to gauge how many of the micro lab directors are actually doing just that, providing that personalized recommendation. So we surveyed ClinMicroNet of 78 lab directors, and the first question that we asked was, does your lab provide interpretive comments? And not surprisingly, the majority of them, so 73%, answered yes, because this is a very standardized thing in microbiology where you're providing a very standardized, pre-prepared comments for certain results. The other area that I found more interesting was whether or not these lab directors were providing more patient, personalized, specific interpretive comments depending on the results. And this number decreased by about 20%. So about 53% of lab directors said yes, and 47% said no. And this is an area that, due to the high complexity of molecular testing and reporting, really needs to progress even further to help guide the clinicians. So as mentioned, Wade showed this slide previously with the different targets, but there are 14 targets included in the panel. And the only thing I really wanted to highlight from this slide is that, one, this is not a standalone test, but also from the package insert, that the results from this test must be correlated with clinical history, epidemiological data, and other findings that may be relevant. And quite honestly, this is really the case for any lab tests out there. You really should be correlating with clinical presentation or history, etc., for any interpretation. So we wouldn't be here today presenting to you all if there weren't some points of concerns worth discussing about the ME panel with regards to, contaminations and specificity. There are concerns for specific targets that are also part of the normal respiratory flora or have increased respiratory secretions. With regards to the sensitivity of the test, the two most common targets that are of concern seems to be HSV1 and Cryptococcus. And then the question about clinical relevance, are all the targets included in the panel really, should it have really been included in the panel? And the one that seems to have the most questions and comments towards is HHV6. And so the ones that are in red right here are the targets that we will be focusing on throughout the rest of this discussion. So with that, the objectives for today is to discuss the clinical significance of a positive and negative panel detection and to really demonstrate the importance of correlating clinical findings for a positive as well as a negative test result. And lastly, to discuss potential strategies of how to interpret the ME panel for these organisms of concern. So I'm going to start off with HHV6, which is a ubiquitous beta herpes virus that is divided into two different species, HHV6A and HHV6B, with HHV6B predominantly infecting more than 90% of all children by the age of 2. Overall, HHV6 is not well understood, and there's minimal understanding of its significance when detected in a clinical sample. A big part of that is that HHV6 is often overlooked as a potentially causative agent of neurological disorders, and workups are often not pursued for various reasons that include limited availability of HHV6 PCR testing in many laboratories prior to the ME panel. What we do know is that HHV6 can cause is a significant cause of febrile xanthum, hemophagocytic syndrome, as well as encephalitis. HHV6B is also a leading cause of childhood febrile status epilepticus. The opportunity here is that diagnostic interrogation of HHV6 by rapid testing approaches can really help us further understand the significance of this pathogen in infectious diseases. So like other human herpes viruses, HHV6 does establish latency after primary infection, and these latent viruses can be reactivated in the setting of another infection or due to a transient immunosuppression, such as in patients with hematopoietic stem cell transplantation, which predisposes them for severe infection. To make it even more complicated is that HHV6 is unique among the herpes viruses in that they can establish lifelong latency via integration into the human chromosome. So if such integration does occur in a germ cell, any offspring arising from that germ cell will have HHV6 in each of their very own cells. In the literature, it's published that the prevalence is about 0.5 to 2% of the population. However, in theory, this number could change, but we're just not really exploring and investigating the number of patients that actually do have chromosomal integration. So I'm presenting this one case today because I thought it really highlights the complexity of HHV6 diagnosis and also provides examples of how in the laboratory you could further investigate, or in your facility you can further investigate the approaches to determining whether the patient has an HHV6 CNS infection or not. So this is a 4-kilo male infant that was born via C-section, was admitted to the NICU for hypoxic respiratory failure, worsening infiltrate on chest X-ray, and hypotension. On day of life 4, he developed a blanching polymorphous erythematous rash of the trunk and extremities, as well as suspected seizures involving the upper extremities. An EEG was performed. an EEG was performed, and it suggested diffuse cerebral dysfunction with focal dysfunction in the right temporal lobe. The patient was placed empirically on ampicillin, cefepime, and acyclovir. The patient remained afebrile and hemodynamically stable until about day of life 11, when he developed an increase in leukocytosis and elevated CRP. A lumbar puncture was performed, and elevated whites was also seen with a neutrophilic predominance. However, there were a great many reds at 38,000. CSF glucose was slightly low, and the protein was elevated. The FilmArray detected HHV6, and HSV blood PCR was also performed, and it was negative, and all other labs were negative except for an endotracheal aspirate that was positive for E. coli on day of life 1. So what the heck do you do with this result? The first question is whether you should treat or not, and this is really dependent on the patient, whether the patient's immunocompromised, and of course the clinical presentation. You also want to determine if this is an active infection or latent infection, and what lab results are available to you that would help with this decision. So for this patient, we initiated ganciclovir and discontinued acyclovir, and for presumed HHV6 meningitis, and this was based on the ME result as well as the presence of the right temporal lobe seizures. The patient also had a truncal rash that was consistent with a viral exanthem the following day. The next question is whether you can use these CSF parameters to help determine between a latent and an active HHV6 infection. And the answer is unfortunately not really. Pleocytosis can often be absent or very minimal if it is present. The table here that demonstrates 11 patients with HHV6 encephalitis has demonstrated very mildly increased leukocytosis in the CSF with this lymphocytic predominance, but overall, generally speaking, it can be very benign. The CSF glucose and protein is also often normal. In our findings of the 4 patients with meningoencephalitis that we've identified since we started testing, only one of the patients had a pleocytosis of greater than or equal to 5 cells, and 2 of the 4 had abnormal glucose or protein. So overall, a normal CSF does not exclude active HHV6 infection. And of course, you would really want to investigate with neuroimaging studies if warranted. For example, an EEG can be a good option given the high rates of seizures and epilepsy associated with HHV6 infection. There are no unique patterns, though, that's associated with neuroinvasive HHV6 infection. An MRI is definitely warranted if there are concerns for HHV6 associated encephalitis. In one study of 54 children with HHV6 encephalitis, 65% had an abnormal MRI, with the most common pathological feature being subcortical restricted diffusion. This was found to affect 62% of the patients in that group. And this diffusion can occur as early as within 24 hours of the symptoms, and it may evolve into widespread T2 hyperintensities. And so, as I mentioned previously, our patient did have a diffuse cerebral dysfunction with focal dysfunction in the right temporal lobe, which supported the thought that he had a HHV6 CNS infection. So overall, establishing HHV6 infection solely from the CSF can be difficult, and what you really want to do is to order additional testing if warranted. For example, quantitative HHV6 PCR from whole blood and CSF can be very useful. It can help rule out chromosomal integrated HHV6, where low copies, viral load copies, typically rule out chromosomal integration. In the literature, it's demonstrated that a viral load of greater than 5.5 logs is strongly suggestive of chromosomal integrated HHV6. In the rare cases where active infection in a non-IC HHV6 patient who have a very high viral load would be expected to decrease significantly within 1 week of antiviral therapy. So that's also a good monitor to rule in or rule out chromosomal integration versus active infection. And of course, you can test for chromosome-integrated HHV6 in patients with high viral load. For example, droplet digital PCR on whole blood sample is offered by University of Washington, and then qualitative PCR on fingernail clippings or hair follicles can also be performed. There is definitely a need for additional testing to specifically detect cases of active infection. Testing of HHV6 RNA may be useful, but there are currently limited data on its usefulness, as well as limited research labs that offer this test. The other issue is that HHV6 RNA test has been associated with lower analytical sensitivity than that of HHV6 DNA, where a limit of detection of greater than 1,000 copies per mil would be interpreted as positive. So in theory, a negative result does not necessarily rule out active infection. The specificity of the test is also a concern, as viral RNA can be packaged within the virion for other herpes viruses such as CMV as well. So with our patient, we did do this investigation. A quantitative PCR from whole blood reported 1.6 million copies per mil, so very high. This warranted sending out for the digital PCR, and it was confirmed to be positive for chromosomal integrated HHV6. And another proof of this is that quantitative PCR 20 days later also, despite therapy, also demonstrated very, very high viral load. So this case really highlights how complex diagnosis of HHV6 active infection can be, and illustrates the steps that would be appropriate when investigating true HHV6 infection. The presence of chromosomal integrated HHV6 in this case does not necessarily rule out infection, as patients with chromosomal integrated HHV6 can develop active HHV6 infection. Additional work, though, is really needed to develop tests to specifically detect cases of active infection in these individuals, which would have helped guide our team in deciding whether the patient really needed ganciclovir therapy. But nevertheless, the patient completed the 21-day course of ganciclovir, was discharged on day of life 40 with final diagnosis of sepsis and meningitis. Neurological assessment throughout the first year of life demonstrated normal development, and the mother's hair follicle was tested and was actually positive for HHV6, chromosome integrated HHV6. So definitely it is a conundrum, and it can be difficult to interpret HHV6 positive results, as demonstrated by some of the literature. The first study that was published in 2018 by Columbia Medical Center looked at almost 800 patients, and they had 15 that were positive at a prevalence of 1.9%. Predominantly in adults, so 80% in adults, and only 3 kids. Of the 15 cases, only 1 was found to be likely encephalitis caused by HHV6, and this was a stem cell transplant patient with a positive MRI. Unfortunately, what was demonstrated in the paper was that 7 of the 15 patients were treated with an antiviral for HHV6, despite the fact that they did not present with true HHV6 infection. This next study that was published just this year in CID it was a multi-center study that looked at almost 1,500 patients, of which 19 were positive, so the prevalence was a little bit lower at 1.3%. They had almost an even split between pediatrics and adults, so 9 peds, of which 88% of these kids had a primary HHV6 infection. And the benefit of actually identifying HHV6 in those 9 children, in the 88% of the children, was that antibiotics were rapidly discontinued due to the detection. And then lastly, with regards to the adults, there were no confirmed cases of HHV6 infection. Overall, there were 0% cases of encephalitis, and they reported that 3 out of the 19, so about 16% of the patients, were treated with ganciclovir unnecessarily for an undisclosed period of time. So what have we found in our institution? We've tested over 1,000 patients so far, of which 25 have been positive for HHV6, so a prevalence of 2.5%, which is a little bit higher than what was previously reported in the other 2 papers. Predominantly male, a majority are admitted to our hospital, and 3 was admitted to the ICU. 88% of the patients that were positive had no significant past medical history, 44% had radiographic evaluation, and about half had ID consults. Additional testing that was done as part of standard of care included whole blood quantitative PCR for HHV6 in about 44% of the patients, of which 9 out of the 11 were positive for HHV6, ranging from 3,000 to 2.8 million copies per mil. Overall, we had 4 cases that were confirmed to be HHV6 meningoencephalitis, 1 that was an HHV meningitis, 11 primary HHV6 infection, and 4 that was considered probable HHV6 CNS infection. They all presented with this bulging fontanelle that was quite interesting, but we were still kind of, I guess, iffy about it. So overall, there was a total of 80% of our patients that were tested that had some sort of HHV6 infection with or without CNS involvement. When we looked at the antimicrobials, 88% of these patients were placed on empiric therapy prior to ME Panel, none of which were ganciclovir. And once we reported the HHV6 result, 6 of the patients were started on ganciclovir or foscarnet within about 7 hours. 4 of the 6 patients were the ones with meningoencephalitis, and the last 2 had a primary HHV6 infection, the first with a CNS demyelination and roseola infantum, and the patient was treated for a prolonged course of oral valganciclovir per the ID attending's recommendation. And then the last patient was a primary HHV6 infection that did not warrant further therapy after the 12.5 hours. We wanted to look at the prevalence of chromosomal integrated HHV6 in our population, and so additional retrospective analysis was done in collaboration with the University of Washington. And so we had 18 of the 25 patients, either blood or CSF, that were tested at UW, and of which 3 of the patients were positive at 16.7%. And what we also found with regards to viral load is that it correlated very well with the literature, where 3 of the positive patients for chromosomal integration had very high viral load at an average of 1.7 million copies, versus the 15 that were negative had an average copy per mil of 120,000. So this is a pretty busy table, but what I wanted to highlight were some key findings in the 4 patients that were diagnosed with HHV6 meningoencephalitis. First off, the HHV6 encephalitis can occur in previously healthy patients, as 3 of the 4 of our patients were previously healthy prior to diagnosis. Overall, although HHV6 detection in the immunocompetent patients are often appropriately ignored, additional testing from whole blood should be pursued in the setting of clinical presentation as well as abnormal MRR findings. Of note, all of the 4 patients had abnormal MRR findings, and we did send out the CSF on our last patient for metagenomics NGS at the UCSF, where only HHV6 was detected. As you can also see, the viral load from whole blood can vary and can be very low, even in the setting of true infection. And then lastly, overall, we found that availability of HHV6 as one of the targets in the ME panel led to a much faster and more definitive diagnosis of HHV6 meningoencephalitis, as well as primary HHV6 infections in our patients, with minimal unnecessary exposures to antivirals. So onwards to the next herpes virus. The other issue is, the potential or presumed risk of low sensitivity for the HSV1 target. So this table here summarizes all or most studies that have compared the performance of the ME panel in detecting HSV1 compared to an alternate PCR assay. In total, there were almost 3,000 clinical samples tested, and of that, there were 10 false negatives and 3 false positives. Focusing on the 10 false negatives, none of the papers that were published really provided additional clinical information to determine whether the cases were true clinical HSV cases. 3 of the cases were weak positives, though, with CTs of greater than 35, and 2 of these cases were spun prior to testing, which deviated from the package insert. The bulk of the false negatives were reported in Dr. Matt Binnicker's study at the Mayo Clinic with 7 false negatives when compared to the Simplexa assay from Diasorb Molecular. Again, there were no CT values or clinical information that was provided for us to kind of investigate further. So an important point about HSV diagnosis, and really for the diagnosis of many other viruses, is that testing from alternate sources can be beneficial. IDSA guidelines published in 2008 does recommend that nucleic acid PCR testing on fluids other than CSF may be helpful in establishing the etiologies of patients with encephalitis. And from the pediatric standpoint, being from a children's hospital, the American Academy of Pediatrics does recommend that whole blood and surface swabs also be tested alongside CSF when investigating neonatal disease for HSV. And this study that was published in Pediatrics in 2016 just illustrates the importance of testing from alternate sources. While detection of HSV from CSF and CNS disease is high, blood can be more helpful in cases of disseminated diseases, and of course, in patients with skin, eye, mouth disease, testing of lesions can dramatically increase the yield of detecting HSV. Testing on alternate sources is helpful and is pursued in certain patients in our institution. Since we've been live with ME, we've had 8 positive HSV cases, and of the 8, 5 had additional testing from alternate sources, and in all cases, all 5 were positive from either blood or swab. On the other hand, in the numbers in red, we had 7 patients that were positive by either blood or swab samples that were negative by the ME panel. And these panels, clinically, from the notes, were not thought to have HSV meningitis, but were maintained on acyclovir therapy due to the high-risk factors such as vesicular rash, and of course, continued on with a full course afterwards. Overall, in the patients that has additional HSV testing in our institution from alternate sources, acyclovir is typically not discontinued until all results are reported out as negative. And with regards to the sensitivity, at least in our institution, we have not identified an issue with the ME sensitivity when compared to 2 different assays. The first one was the Simplexa HSV1/2 assay. That was actually the same test performed in the study from the Mayo Clinic that identified the 7 false negatives. Interestingly, we've actually found high concordance between the 2 tests. And mind you, we did only test 32 samples, but what we found was that the one HSV encephalitis case that was detected by the ME panel was negative initially by the Simplexa assay, and it was only upon repeat that they detected at a CT of 39.8, which is very weak. When compared to a lab-developed test offered by Altona, the 52 samples that we tested, even at a maximum CT of 50, had 100% concordance. So 51 were negative by both, and 1 was positive by both. So there are definitely things to consider when you're bringing on this test. Of course, as part of the verification studies prior to implementation, you really want to, compare the assay against your reference method, or, if you're sending out to a reference lab. And it can be very site-specific, the performance. The other thing is that, that raises the question is how many cycle thresholds is considered enough? Is a CT of greater than 40 clinically significant? In our institution, we run only up to 40 CTs for the majority of our tests. So is more warranted, or is it, unnecessary? The other question is contamination. So if you have an ME panel, if you think the ME panel has contamination risk, then really any molecular test has contamination risk. And in theory, if you have a lab-developed test that requires more hands-on manipulation, you're technically at more risk for contamination. So, you have to kind of think about that as well. And then lastly, as with any other target, clinical education is important, and you can do this by neuroimaging, HSV PCR from alternate sources, CSF parameters, potentially depending on the population. However, what we found is that in most of our encephalitis cases caused by HSV1 or 2, our CSF parameters were completely benign. So what is the significance of a high CT HSV positive? And so Dr. Blake Buchan from the Medical College of Wisconsin very kindly shared this data with me so that I could present it today. And this was an excellent study that they did in their institution on 741 CSF specimens over 14 months, where they tested concurrently, in parallel, between the ME panel as well as an HSV lab-developed test on the Smart Cycler. And HSV1 was performed for 50 cycles, and a CT of less than 45 was considered positive. So HSV2 positives, they've identified 6, and there was 100% concordance between the ME panel and the lab-developed test, with a CT ranging from 31 to 38. Interestingly, though, for the HSV1, only 4 was detected by both assays, with a CT range of 28 to 31. And there was an additional 9 patients that were positive by the lab-developed test only. However, the CTs were between 40 to 45. So what do you do with these results? What do you do with these high weekly positive results? So he very kindly shared with me what he did. So they had the 9 patients as listed here, and of the 9, there were 1 patient that they found to be likely likely cause of HSV meningitis, and with that, the patients were treated for a 2-week course of acyclovir. However, of the 8 patients that were considered unlikely to be HSV meningitis, 2 of the patients were also treated for a full course of acyclovir, and an additional 2 were started on therapy, but then discontinued eventually. So the highlight that I really want to make with that is that any test really can lead to inappropriate therapy, especially when clinical context is not taken into account, and it raises the concern of how sensitive is too sensitive. Having a highly sensitive test may not necessarily correlate with clinical significance as indicated by Dr. Buchan's data, and I think that clinical correlation is extremely important and should really be taken into the context. He also communicated with me that after the extensive evaluation, they do no longer run the test in parallel, and so the ME result is trusted and reported out as a standalone for HSV currently. So with that, I'm going to turn it over to Dr. Butler-Wu, who will be starting her talk with Cryptococcus.
Yes, thank you. This is Bob McGonigal. Dr. Jennifer Diane Bard has given us a magnificent overview of the FilmArray ME panel, set in the context, which I'm delighted to hear, of good lab practice. And I'm sure I've seen that she stimulated quite a few questions and comments from our audience. And so now let me invite the rest of you, if you'd like, to ask questions or make comments as you deem fit. We'll deal with these after our second and final presentation, which is about to begin now. Let me introduce our second speaker. Dr. Susan Butler-Wu is a PhD. She got her doctorate at Tufts University. She is also a diplomate of the American Board of Medical Microbiology and has a special credential from the ASCP. She is the Director of Clinical Microbiology at the Los Angeles County and USC Medical Center and Associate Professor of Clinical Pathology at the Keck School of Medicine of the University of Southern California in Los Angeles. So I'm very pleased to introduce Dr. Susan Butler-Wu.
Thank you very much, Bob, and I'd also like to thank BioFire for this invitation. I'm excited to be here today and talk to you about our findings. So I'm going to switch and talk about the sole eukaryote that's present on the panel. We're going to be talking about Cryptococcus. So as we know, the majority of infections that we see tend to be caused by Cryptococcus neoformans and Cryptococcus gattii. And around 4 years ago, these actually underwent taxonomic reclassification, such that there's now 7 distinct species within what was formerly known as Cryptococcus gattii and Cryptococcus neoformans. And there do appear to be important epidemiological differences between these, and potentially also azole resistance differences between these. But for the purposes of my talk, I'm just going to refer to the old names. So how does one acquire cryptococcal infection? So these organisms are acquired from exposure to soil, birds, droppings, or trees, depending on which species we're dealing with. And what we know is that we tend to see Cryptococcus neoformans infections more commonly in immunocompromised patients, whereas Cryptococcus gattii infections tend to be seen more commonly in immunocompetent patients, although it is increasingly recognized that though these patients are immunocompetent, they may have some unrecognized immune defects. I think Cryptococcus is a really fascinating organism for several reasons, but one of which is that it seems to enter into a sort of dormancy. So you can be exposed to this organism, it can essentially lie dormant, and then later on, essentially, you develop clinical signs of infection. One thing I think that's really special about this organism is it has this propensity to invade the central nervous system. And so although I will be referring to cryptococcal meningitis throughout my talk, really clinically this is considered more as meningoencephalitis because the brain parenchyma is almost always involved with infection with this organism. So in terms of epidemiology of cryptococcal meningitis, we know that there's over 200,000 cases of cryptococcal meningitis that occur annually. The majority of these occur in sub-Saharan Africa. Amongst HIV patients, cryptococcal meningitis is an AIDS-defining illness, and most commonly this is seen when patients have a CD4 count that is under 100. Amongst this patient population, this is a devastating infection with very high mortality rates. And typically, when patients present, they tend to present with a severe onset. In non-HIV patients who have cryptococcal meningitis, typically this is seen in patients that are immunocompromised, obviously for other reasons other than HIV, such as solid organ transplantation or being on immunosuppressive drugs. Interestingly, cryptococcosis is actually the third most common invasive fungal infection in solid organ transplant patients. And here's an example of unique association with a new species that's been subclassified, that Cryptococcus gattii actually has a 70% mortality rate in solid organ transplant patients, as well as higher fluconazole MICs. One of the tricky things in non-HIV patients is that although some can present with severe onset, for many patients the presentation can be somewhat insidious and therefore challenging to make. So how do we diagnose cryptococcal meningitis with respect to laboratory testing? So the historic way that this was most commonly done was with the India Inc. assay. And unfortunately, I think this is really still taught very widely in medical school curricula because we have med students here from various places around the country that rotate here, and everybody refers to the India Inc. But in reality, this is a poor test. It has a sensitivity of only 30 to 50%, although it's up and around the maybe 80% range for patients with AIDS, and it's really no longer recommended. One of the gold standards here is fungal culture. I don't know why I'm not seeing the plate. It was on there earlier. It's a mystery plate that's disappeared, but there's supposed to be a picture of growth. We know that CSF culture is positive in 90%, up to 90% of patients with HIV/AIDS. And interestingly, when you delve into the Cryptococcus literature, there's a lot of use predominantly in research settings of quantitative CSF fungal cultures, which appear to be useful but really aren't used in the clinical setting. I want to also point out that amongst patients with cryptococcal meningitis, routine blood cultures are typically positive in up to 45% of patients. And we certainly have had patients here at our institution that have cryptococcal infection where the first indication that that infection was present was by having a positive blood culture for cryptococcus. So in the next slide, I'm going to talk about the cryptococcal polysaccharide capsular antigen test, or as I'll refer to as CRAG throughout. This is shed by Cryptococcus during infection. However, it's important to note that sometimes serum cryptococcal antigen testing can be negative, particularly amongst non-HIV patients. We also know that when this testing is performed on CSF, that the CSF titers correlate with the organism burden. And that initial CSF titer that we test in the lab does carry prognostic significance for the patient. But this is one of the challenges with cryptococcal antigen testing from the CSF, is that the changes in titer do not correlate well with clinical response. And one of the real challenges associated with this test is the fact that patients can stay positive, have extended positivity. So there's one study that showed extended positivity up to 400 days post-successful treatment. Another consideration that we deal with in the lab is that these tests can have a prozone effect. We've seen that on occasion here at LAC-USC. And when we're talking about the methodologies, there are several available, but the most common are the lateral flow and the latex agglutination. And the lateral flow assay is now considered to be preferred over the latex agglutination. It has higher sensitivity, it doesn't require pronase, and it doesn't appear to have the same the issue with false negatives that had been noted with the latex agglutination for Cryptococcus gattii. It is recommended amongst HIV-positive patients with CD4 counts less than or equal to 100 to do serum cryptococcal antigen screening and to treat those patients. And that has been a successful practice that's been published on quite extensively. There's emerging data to suggest that this threshold for screening and treating may benefit from being increased to less than or equal to 200 cells. So what are some of the diagnostic challenges associated with laboratory testing for Cryptococcus? So it's important to remember that when patients are severely immunocompromised and they have cryptococcal meningitis, they typically have a very high organism burden. And so there's estimates that there's published studies that show that this number can reach up to 1 million CFUs per ml. These patients, because of this very high organism burden, not surprisingly have higher cryptococcal antigen titers and tend to have a shorter onset of clinical symptoms. What's quite challenging, though, is that for non-HIV patients, such as solid organ transplant patients, these patients tend to have lower cryptococcal antigen titers. And indeed, as I mentioned earlier, we can have false negative results for patients with cryptococcal infection. Amongst solid organ transplant patients and non-HIV patients, a first-time positive serum cryptococcal antigen with a low titer of 1 to 2 or 1 to 5 requires very careful consideration. And in a study that was published by Dr. Thiel's group at Mayo Clinic, they observed that up to a third of serum cryptococcal antigen results that had titers of 1 to 2 or 1 to 5 were considered to be false positive, and all of these were in patients that did not have HIV. In line with what Dr. Dean Bard talked about, not being able to use the presence of inflammation on the CSF to rule out infection, that's certainly the case for Cryptococcus as well. And one of the things that's been published upon is that a lack of seeing WBCs in the CSF, along with a high cryptococcal antigen titer and a low glucose, actually is associated with increased mortality amongst those patients. And then lastly, and one of the real challenges for HIV-positive patients is that it can be very challenging to distinguish infection relapse from immune reconstitution syndrome amongst patients with HIV who subsequently initiate antiretroviral therapy. Okay, so I'm here today to talk about the ME panel. So what do we know about the ME panel and its performance for cryptococcal meningitis? Well, the answer is, unfortunately, not a whole lot. So I'm basically going to summarize it in the next couple of slides. What we do know is that in the initial multi-center evaluation that was used to get in vitro diagnostic clearance for this assay, there was an extremely low prevalence of Cryptococcus in that study. So there accounted for only was a prevalence of 0.3%. And one of the tricky things about trying to interpret the performance of this target is the fact that in this study it was not compared to fungal culture, it was instead compared to a fungal PCR. There was only one true positive in the study, so it's published that it has 100% sensitivity, but that's based off of a single true positive, so can't really put much stock in that, unfortunately. And we do know that there was 7 cryptococcal antigen positive patients that were tested ME negative. All of these, and this is important to bear in mind, all of these were patients who were on therapy or had had a previous history of cryptococcal infection. And so what they found was for the 4 other detections, the 2 of these, upon discrepant molecular testing, were deemed to be false positives. So not a very confidence-inspiring performance based off of this initial study. So the next study, and this is a very important study, this was performed by Dr. Binnicker's group at Mayo. And so this was a study where they looked at, with respect to the cryptococcal target, they looked at samples that had been submitted for cryptococcal antigen testing and were known to be positive for cryptococcal antigen. These specimens had been frozen or refrigerated prior to testing. It also included specimens from 7 patients who had cryptococcal CNS disease, where, although I've just told you that monitoring titers isn't terribly useful, that monitoring response to therapy was the reason for ordering this test. And so I've highlighted in the red box here that the authors report that they can't calculate a true sensitivity because of study design, but in effect the sensitivity compared to cryptococcal antigen testing is only 52%. And so when you read the literature on this panel, this is a number that's quoted frequently. It's important to note, though, that the authors did have data on culture results available for 20 of the CSF specimens, and what they found was that the ME panel was positive in 13 out of the 14 of these for a sensitivity of almost 93%. I think one of the reasons there's been quite a bit of controversy regarding the performance of this panel has been because there are now several case reports that have been published documenting false negative ME panel results. So I've put them together. These are all of them, as far as I am aware, that have been published to date. And there's a couple of trends that have emerged. First of all, the majority of these are in patients who are HIV negative. So there's only one where the patient is HIV positive. Unfortunately, there was a study that was published earlier this year in Medical Mycology where they described 4 different false negative ME panels for Cryptococcus, but unfortunately the authors didn't include HIV status. The authors also appear to be PharmDs who didn't include anybody from the lab, so this is a shout out to our PharmD colleagues. Please include laboratorians. We have useful information to provide, and we all work better when we work together. The key point here that I want to make is that if you look at the cryptococcal antigen titers, and when I calculated them up, the median CSF cryptococcal antigen titer of the published false negatives to date is 1 to 20. So these are low, relatively low titer positives. And that's pretty much it, with the exception of one study that I'll talk about later on. So there's really a lack of data on the performance of the panel for clinical testing using prospectively collected non-frozen specimens. So we decided to go back and look at our data here at LAC-USC. So out of over 1,000 tests performed, we had a 6.5% positivity rate. And this pie chart shows you the proportions of positivity by organism. And what you can see is that so 35.7% of our positives here at LAC-USC are Cryptococcus neoforms orchidae. So we have a very high cryptococcal prevalence rate here compared to, say, the multi-center study where it was a 0.3% detection rate. And to put that into context, our positivity rate for Cryptococcus is only a little bit less than when you add up all the positivity for the different herpes viruses that are on the panel. We wanted to delve into how well the ME panel performs for cryptococcal detection in our center. And of over 950 CSFs that underwent clinical ME panel testing, we had 29 CSF specimens that were positive for cryptococcus, either by ME panel, CSF culture, or CSF CRAG testing. Not surprisingly, the vast majority of these are patients with HIV, so 88.5% of our patients were HIV positive. The really, I think, quite shocking part of this is that 35% of our positives were HIV patients who were presenting with initial diagnosis of HIV with cryptococcal meningitis as an AIDS-defining illness. And in many parts of the world, and in the U.S., I should say, HIV is often considered as a chronic disease. That's not the case here in our center. So of these 29 CSF specimens, 79.3% were positive by culture, 82.8% were positive by ME panel, and 100% of our samples, of our 29 CSF samples, were positive by cryptococcal antigen. In terms of the performance compared to culture, when we tabulated it out, the ME panel has a sensitivity of 95.7% compared to culture, so a little bit higher than the Leisman et al. Study. But very importantly, our sensitivity compared to cryptococcal antigen testing is 82.8%, so a lot higher than the 52% that was published previously, and that is because of study design, most likely. In terms of our discrepance, here's a table of our ME panel negative CSF CRAG positive samples, and there's a couple of important trends. What you will notice when you look at the CSF CRAG titer column is that typically our CSF CRAG titers are on the lower end. In contrast, our median titer of ME positive, culture positive specimens was 1 to 2,560. We had a single instance of culture positivity where the ME panel was negative, but again, the cryptococcal antigen titer in that case was 1 to 20, so it was low. So how does this all fit in with sort of more detailed knowledge of the panel? So what we do know from a very nice study that was published a couple of years ago by a group in Uganda is that ME panel positivity correlates with organism burden. So this was a study of 69 HIV positive patients with meningitis in Uganda, and from those 69 patients, 119 CSF samples were available for testing. 52% of patients had an initial diagnosis of Cryptococcus meningitis at presentation, and at the time of presentation, the median organism burden was 8,950 CFUs per ml. When the authors looked and they stratified it because they're doing quantitative cultures, what they found was the ME panel had a 96% sensitivity for detection of organism burdens of greater than or equal to 100 CFUs per ml. And what they also found was that a negative ME panel result had a 95% predictive value for a CSF culture either having a colony count less than or equal to 100 or sterility in a CRAG positive setting. What they finally noted in their paper, which I think is quite interesting and exciting, is that the ME panel was positive in all 3 patients with culture-confirmed relapse, but negative in all 5 patients who had immune reconstitution syndrome. So the reason that it becomes quite clinically relevant is that per IDSA guidelines, it is recommended that cultures be repeated after 2 weeks of induction therapy, and that these cultures should be negative, and that's the goal. So just as a reminder, when patients have cryptococcal meningitis, they undergo 3 phases of treatment: induction therapy, consolidation therapy, and maintenance therapy. So as I mentioned, it's recommended to perform an LP after 2 weeks of induction therapy to confirm sterilization. And we can't use cryptococcal antigen titers in these patients to monitor this, right? Because as I mentioned, they will remain positive. So we're really dependent on having to look and wait for the results of culture. So this is an area that I think deserves a lot of study. There isn't a whole lot of data on it yet, but one of the things to consider is, could ME panel negativity, conversion to ME panel negativity, be used as a surrogate for predicting sterility? It certainly is an area that deserves further study. So you could look at all of this, put it together and say, okay, I'm not even going to waste my time doing the ME panel for Cryptococcus. I'm just going to do, for initial diagnosis, I'm just going to do cryptococcal antigen testing and call it a day. The problem is that that's not so straightforward. There was a really great paper that was published earlier this year for 54 patients in Uganda. All of these folks had neurologic symptomatic cryptococcal antigenemia, so they had positive serum cryptococcal antigen test results, but importantly had negative CSF CRAG results. And what they found, that not surprisingly, there were some of these that had Mycobacterium tuberculosis co-infection, but of these patients, they had 15 specimens, 15 patients where ME panel testing was performed, and 13% of these were positive by ME panel, but had negative CSF cultures and negative CSF CRAG results. In addition, 2 AIDS patients with negative serum CRAG results, there's a case report described where they had no prozone but heavy growth of Cryptococcus neoformans. And if you look at the image here, what you can see is that the patient isolates have these very puny little capsules compared to the wild type strains. So these are patients that have falsely negative cryptococcal antigen test results, both serum and CSF, because of the strain differences. And this phenomenon has been described in both HIV positive as well as in HIV negative patients. So we can't always just rely on a cryptococcal antigen test. So I would say that for overall putting it all together, when we're talking about diagnostics for cryptococcal meningitis, we really need to throw the kitchen sink at it. There's not one-stop shopping for this infection. Okay, so putting it together, how do I begin to interpret these results in the sea of different test methods? So if we look at the first scenario, this is a negative cryptococcal antigen in the CSF with a positive ME panel, no yeast seen by direct exam, and a negative serum CRAG result. Things to consider, is it as possibly an assay false positive? Could this be a capsule variant like I just described? So in this case, it's important to correlate with culture and clinical findings, although that would be true for everything, to be honest. The next scenario is a low CSF cryptococcal antigen titer with a negative ME panel result, no yeast seen, and then also having a positive serum cryptococcal antigen. So this scenario is most likely to represent low organism burden within the CSF. The third scenario is a high cryptococcal CSF titer with a negative ME panel result, may or may not see yeast on smear, and the patient is on therapy. So based on what we know from the literature and also on our findings, this would be most consistent with sterilization or the presence of low organism burden. So where a patient had a high organism burden and now is on their way to sterilization. And then the last scenario would be a high cryptococcal CSF antigen titer with a negative ME panel result where the patient is not on therapy. And in this case, what I would argue is we might want to start to think about things such as possible inhibition or reagent degradation. So one of the case reports of false negative results was in that table I showed earlier, was false negative results not only for Cryptococcus but also for other targets caused by reagent degradation. So that's where retesting is important. And so I would argue that any time you have an unusual result or a discrepancy, you should always look at your MELT curves. And so this was a paper that was published in the Journal of Infection earlier this year. This was a patient who had Neisseria meningitis, meningitis. And what they found was that when they ran it on the ME panel, despite the fact that the inhibitor check looked fine, when they ran it for the Neisseria meningitis target, it was negative. But you can kind of see here that it wasn't a clean curve. There was a little bit of noise up here. And when they diluted the sample 1 to 5, now you can see amplification of that target. And so the important point here is that the inhibition check may not catch all inhibition. And so always look at your MELT curves, because if there's something funky going on, it may be worth doing a dilution to see if there's inhibition. I want to point out this has not been described yet for Cryptococcus, but it's certainly something that I'm keeping in mind as we review results. Okay, in the last just a handful of slides, I'm going to talk about varicella zoster virus. And so I think that it's important to point out that one of the things that has been a great benefit, at least to our setting here, is that we, prior to bringing on the ME panel, had no in-house testing available for viruses. So these were done exclusively at a send-out lab. So really the physician had to have a very high high suspicion to send this out, and clinically we're waiting like sometimes up to a week to get a result back. So it's not really performed in a clinically actionable time frame. So not surprisingly, when we looked at 2 years prior to ME panel, we had only 160 orders for VZV performed on CSF, and we had a 1.2.5% positivity. However, 2 years post-implementation, not surprisingly, as I mentioned earlier, we performed over 1,000 tests, but we still had a similar positivity rate. So we didn't have a bump in our positivity rate, but we have a higher number of overall positives. So we looked at patients. We had 6 patients where VZV testing by the ME panel was positive, but that they did not have a rash. And these we looked at because these are patients where they were a lot less likely to have had clinically ordered VZV testing because they didn't have that rash present. And so what we observed that there was 4 patients that underwent additional testing that was prompted by the ME panel. 2 of these were positive when sent out to the reference lab. One of these patients who had an MRI that was very abnormal, was suggestive of pachymeningitis and bilateral optic nerve thickening, ultimately a couple of days later had an eye fluid sent out where the VZV was positive. We had one patient where the sample was sent out and it was negative in the reference lab. However, when ID saw this patient and they delved into the history of the patient, it turns out this patient had a prior history of shingles, but at the time of presentation her rash had recovered, and now all of these patients were treated, but this patient, because it was deemed to be significant, is now on lifelong suppression with valcyclovir. Okay, so just to wrap it all up, it's important to remember that all lab tests can result in incorrect diagnoses and also inappropriate antimicrobial therapy. And so that's why it's really vital that we correlate any lab test results with clinical and additional findings. So in conclusion, as discussed by Dr. Dean Bard, HHV6 is a significant cause of CNS infections. And it's important to remember that additional HHV6 blood PCR testing and neuroimaging is warranted to confirm the diagnosis. Secondly, screening for HSV from alternate sources is recommended by the IDSA, and it may increase rate of detection. And I think this is a very important point, is that the analytical sensitivity of standalone HSV1 PCRs may not necessarily correlate with clinical significance. With respect to what I've talked about today, I think it's fair to say that the ME panel is most comparable to culture for cryptococcal meningitis, and whether that can be used to predict sterility, I think is an area that's going to be probably investigated. And then putting it all together, syndromic testing can certainly lead to unexpected but clinically relevant detections, and also vice versa. So it's really important that we don't just blindly report results, and that all results really ideally should undergo review by a pathologist or clinical microbiologist. And so in my last slide, these are acknowledgements. Just with respect to that last point, here at LAC USC, all positive results are called to the pathology resident to review the case, and they often discuss it then with myself. And then in Dr. Jean Bard's lab, she's fortunate to have microfellows who do the same. So I'll turn it back over to Bob.
Dr. Susan Butler-Wu, thank you very much for that wonderful presentation. Always when we get into the fungi, we find ourselves in an enormously interesting area, and one that you're beginning to show some great guidance on through your own studies as you've presented them on that data. I do want to say that I know we've run a little bit over in our time. You will be able to hear all of the audio and see all the slides in about 5 days. We'll post them on captodayonline.com. Let me also say we've had a number of questions about areas of reimbursement and insurers. We really can't really answer those in a group today. As always, let me recommend the BioFire field force and representatives to you. They have lots of good answers, and they're very, very helpful on an individual basis. We want to make sure that you do get your questions answered. I'm only going to take 1 or 2 minutes here because we are running over, and people have let me know they need to get back or leave conference rooms, etc. But I thought there's a couple we should clarify. So, Dr. Jean Baird, we had a question, is HHV6 transmissible from mother to fetus?
Yes. So the answer is yes. There are congenital infections that can be caused by HHV6 due to maternal transfer related to reactivation or reinfection. So very similar to CMV in that way.
Very good. And could you just give us once more to reiterate some of your guidance about co-infections that may lead one to think that HHV6 is the leading source of pathology in an infected patient?
Well, typically when you have a co-infection that is detected by the ME panel, and we've had about, I think, just a couple of those. One was a strep pneumonia and an HHV6 that was detected, and the second one, I believe, was an enterovirus and an HHV6 that was detected. And in both cases, because of the other target that was picked up, which made more sense for those patients, the HHV6 was generally ignored, and that's related to the fact that it can be reactivated in the setting of another infection as well.
Yes, thank you. You made that very clear in your presentation. I just thought we should underline it now in these final questions and answers. Dr. Butler-Wu, I'm going to send a question to you now. People are very interested in the IDSA and other guidelines for testing adults and pediatric patients. We've had several people in the audience who attest to a tendency of attending clinicians to overorder panels on adults. Is that your experience as well at USC? And then after you answer, I will also ask Jennifer to comment.
So with respect to the ME panel, I don't feel like it's over-ordered. When you look at the numbers of tests, we're still doing less than culture. And so with the patients, when we've gone and looked at them, it seems reasonable to do. I don't feel like here they've been over-ordered. We don't use any sort of criteria for screening. I know that's an area that has been looked at by others. To be honest, here, when it's ordered, it seems warranted. And this isn't like, poop testing. Basically, the patient has undergone an LP. I think it's reasonable to, if they're going to undergo a procedure like that, to think about also applying molecular diagnostics.
Yes, thank you very much. Jennifer, would you care to comment on this question of guidelines for adults and pediatric patients and the tendency to overorder on adults? Do you have a perspective on that?
So the tendency to overorder on adults, or can I comment on the pediatric side?
Or you can comment on the pediatric side.
Okay. So on the pediatric side, I'm kind of in line with what Dr. Butler-Wu said. Typically, an LP is not something that you take lightly. We currently do not restrict in our institution. That's not to say that we shouldn't in some capacity, but I think that further studies are really needed to really determine what sort of restrictions can be done in each individual institution. For example, we do not restrict based on pleocytosis because in our studies we found that we would have missed about half of all of our viral meningitis or encephalitis if we had restrict based on that. But, we are pursuing and, hoping to publish studies to kind of look at, are there certain potential parameters that we can look at that could help, steward ordering of certain molecular tests.
Very good. And Dr. Dean Baird, I'll give you the last word with that very nice answer. Let me now begin to sum up because it is we're 15 minutes over. I want to thank, of course, Drs. Dean Baird and Dr. Susan Butler-Wu for their wonderful presentations today. These are very rich presentations. There's a lot of literature references. There's a lot of subtleties of interpretation on these panel results, the kind of thing that gave rise to this wonderful title of today's webinar, What the Heck Do I Do with These Results? I'd like to thank Wade Stevenson for his great introduction to the BioFire technology today. And of course, I'd like to thank BioFire for the educational grant that made this webinar possible. Finally, in addition to our speakers and our sponsor, I would like to thank each and every one of you who've taken time today to listen and to read our webinar presentation. We're very grateful that you take the time to do that. I appreciate hearing your feedback. And with that, once again, thanks to all. I wish you a good day, and now we'll bring this webinar to a close.